Assalamu alaikum, everybody, and good evening. Welcome to this Young Leaders Forum webinar on precision endocrinology supported by Surveyor. Precision endocrinology is increasingly reshaping how we diagnose and manage endocrine disorders, moving more toward more of an individual and genetically informed, ethically grounded care. I'm Noura Al-Hassani, consultant and chief of pediatric endocrinology and diabetes division at Tawam Hospital, as well as an adjunct associate professor at College of Medicine and Health Science UAE University. And it is my pleasure to moderate today's session. We will have an excellent speakers, but before we start, we have a few housekeeping for all of you. To start with, the webinar is a live streamed on the Emirates Diabetes and Endocrine Society YouTube channel. There will be Q&A box visible on your screen. Please try to type your questions and mention the speaker's name to be answered during the Q&A session. This session is a CME applied, and you will get it hopefully after like 4 weeks post the webinar and after filling an evaluation form. And the last thing here is that it is a recorded webinar. It will be available on demand on the EDES Institute website. So let's move to our scientific talks. And to start our session, it is my pleasure to introduce Dr. Hissa Buharun. Dr. Hissa is an endocrine consultant and thyroid cancer lead at SKMC. She is specialized in endocrine and diabetes as well as neuroendocrine tumors. Dr. Hissa will speak about monogenic diabetes, which remains one of the best examples of the precision medicine in endocrinology. Her topic will be about genetics and monogenic diabetes, molecular discoveries, and their clinical applications. Dr. Hissa, thank you for joining us, and the floor is yours.
Thank you, Dr. Noura, for the introduction. And it's my pleasure actually to be tonight to you to present this complicated topic, and I hope it will be really beneficial for everyone. So today we'll be talking about genetics and monogenic diabetes, molecular discovery, and their clinical applications. So I will be talking about monogenic diabetes in general, and then we'll be talking about what is monogenic diabetes, why we need to look for it, how we look for it, when and where. Then I will present some of individual cases and conclusion at the end. So how is monogenic diabetes related to precision medicine? Actually, monogenic diabetes represent a crucial area of precision medicine where molecular discoveries have directly transformed the clinical care, allowing for tailored treatment rather than one size fits all. So it's we cannot treat monogenic diabetes like other type of diabetes. That's why it's really important to identify and diagnose patients with monogenic diabetes and differentiate them from other types of diabetes. Before starting with monogenic diabetes, I would like to go or to just review the recent classification of diabetes. As you know that we have first type 1 diabetes, which is an autoimmune destruction of the pancreatic cell leading to absolute insulin deficiency, affect children and adolescents. Then we have type 2 diabetes, which is a combination of insulin resistance and relative beta cell dysfunction, often associated with obesity and metabolic syndrome. Third type is gestational diabetes, insulin resistance due to a pregnancy hormone and pre-existing beta cell dysfunction. Fourth type is monogenic diabetes, which is single gene mutation, MODY genes, causing beta cell dysfunction and impaired insulin secretion. Type 5, malnutrition-related diabetes, such as protein, minerals, vitamin deficiency, and we can see it in actually in young age, less than 30 years. So this is the main classification of diabetes. Now, monogenic diabetes or moody or maturity onset diabetes of young. Those all terms of monogenic diabetes, but they have different also types that we need to know. Um, Monogenic diabetes refer to a heterogeneous group of disorder characterized by diabetes mellitus arising from a defect in a single gene. So it's a single gene mutation, but different genes cause different types of monogenic diabetes. I just would like to start the talk of monogenic diabetes with this story because this is a very famous story in the medical field regarding this patient, Lily. She has been diagnosed with type 1 diabetes at actually 6 month age, and she has been diagnosed with type 1 for 10 years, and she was in insulin treatment for that. Then her parents were interested to attend the medical meeting. They attend the meeting with her doctor, Philipson, and they discovered in that meeting that he was talking about the recent studies about genetic mutation which cause diabetes, different type than type 1, which was discovered in UK. Then they tried to apply that to their parents after the discussion with the doctor, and they did the genetic test for her and turned to be monogenic diabetes and has been shifted from insulin to oral. And this is a common story, and there are also, as you can see, two kids also with the same story. So it's really interesting to see how precision medicine change the management and the life of people. So that's why it's really important to diagnose or to get the correct diagnosis of diabetes. If we talk about monogenic diabetes, we have also different types. Neonatal diabetes, often due to potassium ATP channel pathway variant. And we have also maturity onset diabetes of young, and this is my main concentration of this presentation. Other monogenic form, including syndromic and insulin secretion defect, which is very, very rare. Monogenic diabetes, an overview. The cause, as we mentioned, it's a single gene cause of impaired glucose regulation. So it's affect the glucose regulation, action, and secretion. Presentation, it's often present like type 1 or type 2, but has distinct diagnosis and treatment implication. Importance of early recognition can enable target therapy and improve long-term outcomes. Here in this table, we can see many types actually of monogenic diabetes, and maybe it's around the discovered one, maybe around 40, but this is the well-known types of monogenic diabetes. I will just start with the common one, the classical monogenic diabetes, classical moody. We have moody 1, which is has a mutation in HNF4A. The frequency is 14%. And usually it's a neonatal diagnosis. They present with hypoglycemia, fetal macrosomia. They respond to a low dose of sulfonylurea. They have progressive beta cell failure, require insulin later in life, and it's autosomal dominant. Moody 2, there is a mutation in GCK gene, 22%, and it's a classic Moody. They present mainly with mild fasting hyperglycemia. Does not require treatment except during gestation, determined by GCK mutation status of the fetus. Moody 3, HNF1A, it's 33%. This is the most common. Also, it's a classic Moody. It's mainly presented with a glucose urea, low renal threshold. They have low, and we will talk later in the pathogenesis about this and why they have low renal threshold. And they respond to low dose sulfonylurea initially, then they have progressive beta cell failure, require insulin later, they have risk of complication. Moody 4, IBF1, BDX1 less than 1%. Also, this is classic Moody heterogeneous mutation causing Moody or type 2 diabetes. Then we have Moody 5, HNF1P, 6%. They presented with renal cyst, diabetes, pancreas hypoplasia, exocrine insufficiency, beta cell defect, low magnesium, gout, altered LFT, autism. Moody 6, neuro OD1, 1%, also classic Moody, heterogeneous mutation causing Moody, or homozygous mutation causing neonatal diabetes mellitus. Moody 7, KLF11, also this is a very rare. Moody 8, CEL less than 1. Moody 9, BAX 4, and I have one patient also I will present later with BAX, which is very, very rare. The other types, as we can see all here, Moody 10. Moody 10, 2%, it's a classic Moody. Mild defect can present as Moody, whereas severe defect can present as a transient neonatal diabetes or permanent neonatal diabetes. Moody 11, very rare. Moody 12, ABCC8, 4%. It's a classic Moody, present with the relapse of transient neonatal diabetes, isolated Moody with no history of transient neonatal diabetes, respond to low dose of sulfonylurea. As we can realize, most of the Moody types, they respond to sulfonylurea. Moody 13, KCNJ11, 2%. They are also considered a classic Moody, manifest as relapse following a transient neonatal diabetes or isolated Moody with no history of transient neonatal diabetes. Moody 14, ABBL1, less than 1%, very rare. Also delayed onset of Moody with low penetrance and less severity. RFX6 Moody, this is less than 1%. Then we have other gene, as you can see here in the table, and I don't think it's really important to mention on that scheme. Here, this is also a neonatal, different type of neonatal diabetes with other genetic mutation, as you can see here. So the most important that we take from this, that it's mainly autosomal dominant. There is autosomal recessive inheritance, but the most common is autosomal dominant, and most of them, they respond to sulfonylurea. And the most common Moody type, the one we mentioned earlier, they have a distinctive feature. This is a case of Moody BAX4 mutation that I get encountered during my training. And the patient presented with, actually, she has been diagnosed with type 1 for a long time. When she was young, before age of 20, then we realized that she's not requiring a lot of doses of insulin. Then we reduced the insulin, we put her in sulfonylurea, we sent for genetic test, and it came back as a BAX4 mutation. But to be honest, the genetic significance at that time was not very clear. Here we can see the gene, and this is explain all the genetic defect which can possibly happen in monogenic diabetes at all cellular level. We can see that NHF1A gene, which is mainly in the nuclear part, it's crucial for pancreatic beta cell function and development, regulating gene related to insulin synthesis, secretion, and glucose metabolism. So any mutation in the NHF1A lead to progressive beta cell dysfunction, reduced insulin secretion in response to glucose, and lower renal threshold for glucose. That's why they will get glucosuria. Then HNF4A gene, also at the nuclear level, along with the transcription factor like HNF1A and NHF1B, regulate insulin gene expression and control gene involved in insulin secretion, glucose transport, and metabolism. HNF1B, also in the gene, in the nuclear level, it's also important and present at the kidney. That's why the patient with NHF1B, they present with renal cyst, renal dysplasia, urinary tract malformation. There is other also genetic involvement, as we can see here, which affect the biosynthesis and secretion of insulin. And it's worth to mention about the two other genetic pathogenesis. GCK gene. GCK gene, as we can see here from the picture, it's affecting the glucose transport and the synthesis. So it's lead to raise the threshold for glucose stimulating insulin secretion, and this results in mild stable hyperglycemia without risk of complication. So that now we can understand why in those patients they just have mild hyperglycemia without complication. At AB, then we have the last gene ABCC8 and KCNJ11, which, as we can see here, they are presented at the cell surface at the potassium channel. So mutation represent ion channel disorder that are also responsible for neonatal diabetes. Why it's matter clinically to know about the genetic or the monogenic diabetes? Because there is a risk of misclassification, which can lead to ineffective or unnecessarily intensive treatment, as happened in the story of Lily. Target medication response, because as we mentioned also, type 1, they have different treatment than monogenic diabetes, and most of the monogenic diabetes respond to sulfonylurea, so will make a difference. Genetic diagnosis benefit supports screening at risk of relatives. So if we get the genetic diagnosis, we will also check in the family if there is any risk, or if and it's allow us to diagnose patients early. Single gene disorder, as we mentioned, the monogenic diabetes single gene disorder, a pathogenic variant will influence, and one gene can drive diabetes through defined biological pathway, as we mentioned in the previous slide. Inheritance also important to know, and we know most of the genes inherited by autosomal dominant inheritance, which means that the offspring, they can have 50% chance of getting the gene. Phenotype characteristic can be age dependent and evolve over time. So this is the main concept about single gene disorder. What we need to know as a clinician. We are not geneticists, and we need to know a few things important about this diagnosis to be able to manage the patient. So we need to know the age of the onset of diabetes or monogenic diabetes, because as we know, they present in adolescence, or early adulthood. Also, we need to know about the inheritance pattern, which showed, as we said, it shows autosomal dominant inheritance with multi-generational pattern. Also, we need to know about the clinical course of the disease, because it can be mild, progressive, or variable, depend on the gene mutation and the involvement of the gene. There is some clinical clues of monogenic diabetes or MODY. It's early onset of diabetes with a strong family history. We should always suspect MODY. Preserved insulin production compared with the classic type 1 diabetes. Absence of autoimmune markers that we see in type 1 diabetes. That also all support MODY. So when we suspect any patient with MODY by age, phenotype, family history, we do send for autoimmune status, C-peptide level, insulin level. Then we choose appropriate genetic tested, and usually this will be decided by the geneticist. So for me, I always refer to our genetist, and I'm lucky to get actually excellent geneticists at our hospital to diagnose those patients. Also, what can support the diagnosis, MODY risk calculator. As you know, everything now have calculator, but for MODY, there is several risk calculator has been applied, but the validated one is validated by University of Exeter group, which is known for monogenic diabetes, and it's mainly assess the risk for GCK MODY, HNF1A MODY, and HNF4A MODY for a patient between age 1 to 35 years old Caucasian. You can go through this website, and will take you directly to the calculator to calculate the risk. Okay. And if anyone interested in monogenic diabetes, this is a yearly training course happened in Exeter. I did attend once. It's in UK, but in the last few years they are doing it online, so you can just register for this year. It will be in October, and you can attend a virtual course, which is really helpful if you are interested. Going back to our diagnostic approach, we have some biomarker which can help us in diagnosing or support the diagnosis of Moody. And as we know, genetic test is the diagnostic test, but also biomarkers can help us to support the diagnosis. Some biomarkers like high sensitivity C-reactive protein and some studies found that high sensitivity reactive protein are low in HNF1A Moody compared to other types of diabetes. So it's helpful only in case of HNF1A Moody. Other biomarker, as we mentioned earlier from the presentation of one of the Moody's type, the glucose urea, because they have low threshold and they have defect in the promoter region of the sodium glucose co-transporter 2 and demonstrate low renal threshold because of decreased transporter expression. That's why they will have glucose urea. And they used to actually the suggestive diagnosis which support the diagnosis of HNF1A. If we have presence of glucosuria at blood glucose less than 10, okay, could 10 millimole per liter could serve as an indicator of Moody subtype, which is HNF1A. Then other biomarkers, we have apolipoprotein and high-density lipoprotein. HNF1A and HNF4A genes play key roles in the transcription of protein, regulating apolipoprotein and high-density lipoprotein. And they found that HDL level are elevated in HNF1A Moody compared to type 2 diabetes. So as we realized, most of the biomarkers, they are specified to specific subtypes of Moody. Then we have something called urinary C-peptide creatinine ratio. And they used it in adult with diabetes for over 5 years. They do 2 hours post-meal urinary C-peptide to creatinine ratio. If it is more than or equal 0.2 nanomole per millimole, differentiated HNF1A Moody or HNF4A Moody from type 1 with 97% sensitivity and 96% specificity. And this is really helpful. So for NHF1A, as well as most of the biomarkers going with NHF1A, so the clinical screening strategy utilize 4 biomarkers. BMI of less than 28, high sensitivity C-reactive protein, we say it's low, less than 0.75, fasting insulin less than 102 picomole per liter, and HDL cholesterol more than 1.1 millimole per liter. Thus, all indicator for HNF1 Moody. Distinguishing monogenic diabetes from type 1, as we know, it's one of the differential diagnoses. First, by autoantibodies and monogenic autoantibodies may be absent in monogenic form. C-peptide level can be preserved longer depending on the subtype. And the response to treatment, therapy response like sulfonylurea can differ substantially. So these are the main 3 things that can differentiate between type 1 and monogenic diabetes. Also, how we can differentiate between monogenic diabetes and type 2. First, a younger patient, a family history indicate monogenic etiology. Body habitus like and metabolic syndrome may be less prominent than in monogenic diabetes than type 2. Target treatment can replace long-term insulin dependence in selected subtypes. So the main 3 things here, the body habitus and the metabolic syndrome, younger age with family history, and treatment target. This is an overview which help to approach a patient with unknown diabetes or um, to differentiate between different type of diabetes. You can go through it slowly, but it's really helpful to know how to manage the patient. The first part is for neonatal, for the pediatric group, and here for adolescents, and it can be used mainly for adolescents and pediatric also. Um, Who to test for monogenic diabetes? Does every patient need to be referred to genetist to do genetic test? As we know, genetic test is costly, and not everyone can get the capability to see genetist, or it's not maybe available everywhere. So there is specific patient that we should send for genetic test, and depends on the recommendation. Actually, here it says all patients diagnosed with diabetes before age of 6 months should be tested for monogenic forms of neonatal diabetes, and this is grade A recommendation. All patients diagnosed between 6 to 12 months should be tested for monogenic forms of neonatal diabetes using large gene panel, and women with gestational diabetes and fasting glucose above 5.5 millimole per liter without obesity. That was actually a new information for me when I was preparing the presentation. Also, those with persistently mild hyperglycemia, A1C between 38 to 62 millimole per mole, or fasting glucose 5.5 to 7.8 millimole per liter at any age with absence of obesity should be tested for GCK etiology. People without obesity under the age of 30 who are either autoantibody negative or have retained C-peptide level should be tested for monogenic diabetes using large gene panel. I will try to finish because I think I'm run out of time. And after genetic test, you need the result should be interpreted by the genetist to understand the pathogenicity. Is it pathogenic, likely pathogenic, or is it the variant of undetermined significance? There is different type of genetic testing. I don't think we need to know that, but just to understand that there is exosome or genome sequencing, and this is give a wider genetic panel result. Then why it's important to go for genetist for a family screening. It's really important for counseling to discover who's at risk, to screen the indicated family member, and for also offspring risk of getting the gene. As we mentioned, the main treatment for monogenic diabetes is sulfonylurea. Most of them, they respond to sulfonylurea except few types, and they might progress to, they have progression and they may require insulin. After diagnosis, we need to monitor the patient glucose control, hypoglycemia risk. Also, we need to monitor their A1C level. What if the patient, they did ask how they get moody gene if they are the first one in the family? Individual with moody, they might they might be the first one in their family to develop the mutation. They can then pass it to the children by 50% of time. So this is one possibility. The other possibility that their parents may have moody, but they have not been tested before. How to test monogenic diabetes? We mentioned that this is the different type of genetic test. I don't think we need to go through it. This is just a case presentation brief one of one of my patients that I follow in the clinic who developed actually diabetes after growth hormone replacement for short stature, and then they thought she has type 1. She has negative antibody. She has very strong family history, as we can see, of diabetes at young age and type 1 diabetes. We sent genetic test at that time, maybe 10 years ago, and it was negative for glucokinase deficiency. It was specified at that time. And still she's not on insulin. She's monitoring her blood sugar without insulin. We did refer her again to explore the genetic mutation for a possible other type of monogenic test, but still it's negative in the past due to limited panel. Genetic counseling, as we mentioned, it's important to discuss the risk of offspring. And this is also just an overview of the management of monogenic diabetes and what we need to do and how to follow the patient. And also here mentioned for the pregnancy, how the patient with the gestational diabetes, how we mentioned that and how we suspect monogenic diabetes. Challenges that we can face with monogenic diabetes, the next generation sequencing, which is the genetic test panel, because sometimes it's not expanded to all the type of the mutation. Diagnostic gap, a lot of patients will be misdiagnosed for a long time with different type of diabetes, age and ethnicity limitation, and cost effectiveness, as we know, and the availability of the genetic tests is not easy to find everywhere. Here, just showed the different type of monogenic diabetes, which can be misdiagnosed with other type of diabetes, either type 1 or type 2, or even GDM. What is latest and the literature? Latest is maturity onset diabetes of young and neonatal diabetes are primarily caused by mutation in over 40 known genes, emerging next generation sequencing continuously to be the new variant that expand the phenotype of these disorders. So there is a lot of mutations that is not discovered, but there is over 40 known genes until now. So we expect to get a lot of rare maybe mutations. This is also one of the cases that I did present recently in a conference, who presented with osmotic hyperglycemia in the emergency, and he thought that he had the type 2 diabetes, and he was not compliant, he was not following for some time. Then we did see him in the clinic, we did evaluate him, his antibodies negative, C-peptide normal, insulin level normal. We started him on insulin at that time because of the glucotoxicity. Then we sent, because he's thin, we suspect that he might get monogenic diabetes. I sent him for genetic test, and it came back positive for maybe 5-HNF1 beta. We shift him from insulin slowly to sulfonylurea, and you can see here how his blood sugar improved. Initially it was uncontrolled, then improved. The control improved with changing the treatment. So it's really important, because we did also send the patient for genetic counseling because he's young and he's married, and he will get also kids that he needs to know the risk for to get to pass this mutation to the offspring. So in the future, they try to find a more effective non-invasive biomarker, as we mentioned, the urinary C-peptide, and establishing more cost-effective screening program to reduce diagnostic delay. And I think that was my last slide. It's just in conclusion, I just would like to mention that management of monogenic diabetes opened the window for precision medicine, largely made possibly by broader availability and accessibility of next generation sequencing. Target gene panel offers specificity and cost effectiveness, although whole exosome sequencing offer wider opportunity for gene discovery. So it's mainly about the genetics. So always refer the patient to the right person, the geneticists, if you suspect monogenic diabetes. And that's all. Thank you so much.
Thank you, Dr. Hissa, for the excellent overview on monogenic diabetes. please, everyone, post your questions in the Q&A box to be answered later on the Q&A session. So let's move to our next talk, which should be bringing precision endocrinology into more of a clinical practice through a case-based discussion. It is my pleasure to introduce Dr. Reem Jaffer Al-Arqan. She is a consultant endocrinologist at King Fahd Hospital of the University, assistant professor at Imam Abdurrahman bin Faisal University, as well she is head of the endocrine section and director of the Diabetes Center. Dr. Reem will present the hypophosphatasia and the role of genetic workup. Dr. Reem, you are welcome, and over to you, please.
Good evening, everyone. Thanks for the organizing committee for the kind invitation, and thanks for the chairperson for the kind introduction. So I'll present a case where we can elaborate about the precision medicine. She was a young female who presented with recurrent fractures, and we will show how the genetic workup in this case helped to reach the definitive diagnosis and provide the optimum management. So she is a 40-year-old female. She presented to our endocrine clinic for the first time in December 2024 for evaluation of recurrent fractures, which was not preceded with a history of significant trauma. So if we look at the list of or causes of fractures in young premenopausal females, we have a long list of causes including endocrine causes, metabolic bone diseases, nutritional malabsorption, renal rheumatologic causes, and medications and lifestyle. Looking at the endocrine causes, mainly hyperthyroidism and hyperparathyroidism, in addition to Cushing or hypogonadism, could lead to fractures in young premenopausal females. Metabolic bone diseases like osteomalacia, hypophosphatasia, osteogenesis imperfecta, and hypophosphatemic disorders. Nutritional disorders like calcium and vitamin D deficiency, malnutrition. Malabsorption like celiac disease, inflammatory bowel disease, and bariatric surgery, kidney diseases like CKD, renal tubular acidosis, rheumatologic diseases like rheumatoid and SLE, and medications primarily steroids. So back to our patient, she was a premenopausal female. She was not known to have chronic illnesses, and she was not on medications except calcium and vitamin D. And she did not use steroids before, and she had regular period. Her history goes back to her childhood when she used to develop recurrent loss of teeth, for which she required multiple dental procedures and implants at different times during her life. She also suffered from long-standing bony pain during her life. The patient developed recurrent metatarsal fractures without history of trauma, especially at the left foot, about 3 times. The last one was almost 1 month prior to presentation to our clinic. She also developed leg pain 1 year ago, and she was told to have a fracture. This was her previous radiological workup, which she brought with her when she presented to the clinic. So she had multiple x-rays that documented the presence of fracture. For example, in 2023, she had left fifth metatarsal fracture at the left foot. Again, 2024, she had again another fracture, and also another fracture in the same year at the third metatarsal bone. She sought medical advice previously multiple times in different orthopedic and endocrine clinics, and BMD was done multiple times as well. The lowest Z-score was minus 1.4 at the left proximal femur and minus 1 at the right proximal femur. Other workup that were done, she had normal TSH, vitamin D, calcium, and BTH, and magnesium level was at the lower side of normal range. She was advised to continue on calcium and vitamin D replacement. Upon obtaining further history, she mentioned that 3 of her brothers, who are already older than her, had similar problem with documented femur fractures, and they already underwent internal fixation. However, no clear diagnosis was provided to them. The patient is a mother of 1 daughter who is 13-year-old, and she is doing well and healthy. On examination, her weight was 51 kilogram, height 148 cm, normal BMI 23 kilogram per meter square. Vitally, she was stable. Examination was remarkable for cast covering the left foot due to recent fracture. Initial investigations which we did basic labs including CBC, which was normal, TSH was within normal 0.82. She had normal calcium of 2.3 with normal phosphorus and BTH. Vitamin D was already at the upper side of normal range. The upper limit was 250 and she was 287, but she was already on replacement. She had negative celiac screen and she had normal estradiol and gonadotropin levels. This was her left foot X-ray, which was reported as old fracture of the 3rd and 4th metatarsal bone and non-healed left 5th metatarsal undisplaced fracture without intra-articular extension. We did also left femur X-ray, however, it was negative for fracture. The BMD showed again z-score of -1.4 at left femur and -1.1 at the right femur, and it was normal at the lumbar spine. So in summary, she was a young patient with recurrent metatarsal fractures. She had dental problems during childhood. She complained of chronic bony pain, and she had positive family history in 3 of her siblings. So looking at the genetic or familial causes of recurrent fractures, it include mainly hypophosphatasia, osteogenesis imperfecta, X-linked hypophosphatemia, autosomal dominant hypophosphatemic rickets, and osteopetrosis. Hypophosphatasia, usually those patients present with premature loss of teeth, recurrent stress fractures, bony pain, and positive family history. And usually in the laboratory, we will find low alkaline phosphatase and high substrates, which are usually phosphorylated by the alkaline phosphatase, like vitamin B6 and phosphoethanolamine. And then radiologically, you will find the evidence of fractures, and you can confirm the test by doing the genetic testing and demonstrating the genetic mutation in ALBL gene. Osteogenesis imperfecta, usually those patients will have childhood fractures, blue sclera, hearing loss, dentogenesis imperfecta. Usually they have normal calcium phosphorus alkaline phosphatase. Radiologically, you could demonstrate the evidence of osteopenia, multiple fractures, vertebral fractures, and again, you could reach the diagnosis by demonstrating the gene mutation in COL1A1 and A2 gene. X-linked hypophosphatemia, usually those patients will have mainly low phosphate with normal calcium and high FGF23, and they will present with childhood rickets, short stature, bony pain. And again, you could confirm the diagnosis by finding the gene mutation in FEX gene. Autosomal dominant hypophosphatemic rickets is similar to X-linked hypophosphatemia, however, with variable age of onset. Again, they will have high FGF23 but low phosphates, and you can confirm the diagnosis by finding the mutation at FGF23. Finally, osteopetrosis. Again, those patients present with recurrent fractures, cranial nerve compression, and positive family history. You will find diffuse skeletal sclerosis in radiological imaging, and the diagnosis is confirmed by the genetic testing. So in this patient who is young, she has recurrent metatarsal fracture, dental problems, chronic bony pain, and positive family history. We put as working diagnosis hypophosphatemia, which needs to be ruled out. We did alkaline phosphatase for the patient, and it was very low. So the lower limit was 46. For her, it was 11. And when we went back to her medical records, we found that she already had a low alkaline phosphatase even previously when she did a blood test in 2019. We did also vitamin B6 and we found it as extremely high. The upper limit is 110 and for her it was 814. So the patient was called after the above findings and we informed her about our working diagnosis and that genetic testing is required. At that time, she volunteered with the information that one of her brothers who had the fracture, he already underwent genetic testing. However, he was not offered the treatment because the treatment is expensive or it is not available also at his treating center. So we did the genetic testing for the alkaline phosphatase liver, bone, kidney gene, and it came to be as positive, confirming the diagnosis of hypophosphatasia. And the mutation that she had, it was homozygous, likely pathogenic variant in ALBL gene, and it was consistent with the genetic diagnosis of autosomal recessive ALBL-related hypophosphatasia. So our final diagnosis was autosomal recessive ALB-related hypophosphatasia. So after that, the patient was referred to another facility to start the enzyme replacement, which is the S-phosphate alpha. She was already started in the medication around mid-2025, and she was already on regular follow-up in the other center, which is National Guard in Riyadh. She was last seen in our clinic in February of this year, and at that time she reported improvement in her symptoms, especially less bony pain, and she did not have fractures since she started the medication. If we look at her family pedigree, so she is a product of consanguineous marriage. Both of her parents died, and she already had 3 affected brothers, and she was the 4th affected sibling, and she has another 2 siblings. They were asymptomatic. So we offered to do genetic testing for the family. Only one of her brothers, who is 47-year-old, agreed to be tested for the gene mutation. When he presented to the clinic, he reported again positive history of multiple dental procedures and implants at childhood, and he already developed 2 fractures. Both of them, they were at the leg, and also the other fracture was at the femur. So the first fracture was at age 36 years and it required metallic fixation in the right leg. The second one was at age 39 years and it was at the left leg and femur. This patient was already followed up in another facility and he was treated with teriparatide for 1 year and then it was stopped. At the time of our clinic visit, he was not on any medication. Again, we did for him genetic testing and we confirmed the presence of the homozygous mutation. And again, we transferred this patient to the another facility to receive the S-phosphate alpha since it was not available in our center. This patient, she had only one daughter who is 13-year-old. So we offered also to do genetic testing for the daughter. They agreed and we saw her in the clinic. She was doing well. She was asymptomatic and we did alkaline phosphatase for her and it was within normal. And the genetic test confirmed the presence of heterozygous pathogenic variant. So most probably she is carrier for the disease. However, of course, she needs follow-up as well. So speaking about hypophosphatasia is a rare inherited metabolic disease associated with compromised bone mineralization that manifests as a fracture and pseudofracture. It is caused by variants in ALBL gene, which encode for tissue non-specific alkaline phosphatase. The symptoms are not confined to the skeletal manifestation, and it could affect other systems as well. Alkaline phosphatase is critical for metabolizing 3 substrates, which are pyridoxal 5-phosphate or B6, inorganic pyrophosphate, and phosphoethanol amine. That's why deficiency of alkaline phosphatase will lead to accumulation of these substrates, and this is what we found in our patient. When we checked the vitamin B6, it was already high. Now, alkaline phosphatase, as I said, it has 3 key substrates. Usually convert these key substrates into inorganic phosphate and pyridoxal. And with the deficiency of alkaline phosphatase, they will have accumulation of these key substrates. What is the prevalence of hypophosphatasia? The exact prevalence is not much studied. However, in some reports, for example, in countries like Canada, US, they reported prevalence of 1 in 100,000 live births. And in Japan and Europe, they reported around prevalence of 1 in 300 to 500,000 births. What is the biologic function of alkaline phosphatase? We know that alkaline phosphatase is important for bone mineralization. How does it do the bone mineralization? It dephosphorylates inorganic pyrophosphate into inorganic phosphate, and then inorganic phosphate will bind to the calcium level to form the hydroxyapatite crystal, which is important for bone mineralization. In patients who have hypophosphatasia, they will have deficiency of alkaline phosphatase, so they will have accumulation of the inorganic pyrophosphate, which will lead to reduction of inorganic phosphate. So as a result, they won't be able to bind to the calcium level to form the hydroxyapatite, so they will have accumulation of calcium, leading to impairment of mineralization. In addition to that, alkaline phosphatase is very important to dephosphorylate pyridoxal 5-phosphate or vitamin B6 into pyridoxal, and that in pyridoxal usually cross the blood-brain barrier, which is converted in the brain again into pyridoxal 5-phosphate, which is important cofactor for synthesis of several neurotransmitters. However, in patients who have impairment of alkaline phosphatase, they will have increase in pyridoxal 5-phosphate and reduction in pyridoxal, and that will lead to accumulation in the serum of pyridoxal 5-phosphate, however, reduction of it in the CNS, which will result in vitamin B6 responsive seizures in those patients. Now, alkaline phosphatase is encoded by ALBL gene, which is localized in chromosome 1p34-36-1, and it consists of 12 exons and distributed over 50 kilo base pair. The inheritance of hypophosphatasia could be inherited either as autosomal recessive or autosomal dominant. Autosomal recessive, the risk of having the disease will be 25% if of both the father and the mother are carrier for the disease. And for autosomal dominant, if only one parent is affected, then the risk to have the disease will be 50%. Hypophosphatasia is a chronic heterogeneous disease, and it is a progressive disease as well. And the manifestation of the disease could be presented at different stages of the life. So it depends on the severity of the disease. So beginning from early life, usually infants, if they are affected by the disease, they could present with respiratory symptoms, progressing to cranial abnormalities at a median age of 1 year. Early in life, those patients could have a premature loss of teeth, and then in mid-life, they could have multiple fractures and bony pain, and that could lead to surgery at older life or gross motor and ambulatory abnormalities. Again, as we said, the manifestation of hypophosphatasia has different symptoms depending on the age of onset. So, for example, looking at adult age similar to our patient, those patients will present with fractures, osteomalacia, chondrocalcinosis, pseudogout, chronic pain, adult tooth loss, and abnormal dentition. So hypophosphatasia is very well-known cause of developing multiple fractures. So, for example, in this retrospective chart review study, they found that the percentage of patients who sustained more than 10 fractures, they were almost 26% of those patients developed more than 10 fractures during the course of their life. And as we said, it's a systemic disease, so it involves skeletal, renal, dental, muscular, or rheumatological, and also it has important disease burden and limitation in the activity of the daily life, and with significant impairment of the physical function. And most of those patients who have hypophosphatasia, they will have different manifestation, as I said, demonstrated by pain, dental abnormalities, skeletal abnormalities, constitution, metabolic, renal abnormalities like hypercalcemia, hypercalciuria, and hyperphosphatemia, nephrocalcinosis, and kidney stones, rheumatological manifestations like chondrocalcinosis, pseudogout, muscular abnormalities, respiratory like pneumonia or respiratory failure, and a neurologic manifestation like seizure, craniosynostosis, cognitive delay, and developmental delay as well. And as a result, this will lead to impairment of the quality of life because of missed motor, milestone and developmental delay, severe chronic pain, failure to thrive, and growth restriction in children, significant disability and difficulties with activities of daily living, and resulting in limited functionality and immobility. How to diagnose hypophosphatasia? Diagnosis may be relatively straightforward when clinical, laboratory, or radiologic signs and symptoms are present. And the most important finding, which will drive the testing for hypophosphatasia, is having persistently low level of serum alkaline phosphatase activity adjusted for age and sex matched control. That could be accompanied by normal or low level of vitamin D, high calcium, low, of course, alkaline phosphatase, high phosphate, and normal PTH. However, often the diagnosis is not so simple. So to diagnose those patients, there is a consensus recommendation which was developed by international working group, and they put a criteria to diagnose hypophosphatemia in children and adults, and it included major criteria which indicate more than 50% of the published cases they had this criteria, and minor criteria which was found in less than 50% of the published cases. So to diagnose hypophosphatasia, the most important diagnostic criteria is to have first persistently low alkaline phosphatase adjusted for age and sex. After that, we have 4 major criteria. The 4 major criteria include having the genetic mutation in ALBL gene, elevation of natural substrates of tissue non-specific alkaline phosphatase, presence of atypical femoral fracture, and recurrent metatarsal stress fractures. The other minor criteria in adults are chronic pain, nephrocalcinosis, early age traumatic loss of teeth, poor healing fracture, and chondrocalcinosis. For our patient, she already had persistently low alkaline phosphatase. She had genetic mutation in ALBL gene. She already had elevation of natural substrate of vitamin B6, and she had recurrent metatarsal fracture. So already 3 major criteria. And she had also chronic pain as well, with poor healing, as well as early atraumatic loss of teeth. So just to keep in mind, key consideration in the diagnosis of hypophosphatasia, that genetic confirmation is not obligatory criteria if you have the other major criteria, because you have to have at least 2 major criteria, and always focus on the current age rather than the age of onset. And DEXA scan was not put as one of the criteria to diagnose hypophosphatasia because of its limited utility in assessing deficient bone mineralization in those patients. And always keep in mind the functional impairment, especially impaired mobility, muscle weakness, and pain. Unfortunately, most of those cases, they're diagnosed late in the course of their disease. For example, in this study, they found that most of those patients, they are diagnosed at a median age of 47.5 years. However, they have symptoms at least 10 years earlier before the time of diagnosis. And when they broke the age of onset, they found that most of the young patients with ages of from 0 to less than 18 years, they had almost median 24.5 years in order to be diagnosed, and that was less in the adult age group in above 18 years. It was only 3.8 years. So again, most of those patients, they are lost in multiple clinics, including orthopedic and rheumatology clinic, and they are misdiagnosed as either fibromyalgia, chronic back pain, osteoarthritis, or multiple other diagnosis. So for example, in this study, they looked at 9,000 rheumatologic outpatient cases, and they found that when they screened those patients, 500 of them, they had low alkaline phosphatase. And then after exclusion of some of the cases where it was only transient reduction alkaline phosphatase, or some of the patients where they lost follow-up, or some of them that did not participate, they tested those patients, and they, out of 73 cases who had low alkaline phosphatase of less than 40 units per liter, when they did the genetic testing, they found 13 patients, they had positive ALBL variant positive cases. The management of those patients is multidisciplinary, including physical therapy, surgery, bone-directed therapy, dental care, analgesic, supplements, supportive care, and enzyme replacement therapy. If we look at the role of osteoporosis treatment in the management of hypophosphatasia, in general, anti-resorptive medication should be avoided, including bisphosphonates and denosumab, and because those medication could worsen mineralization and increase the risk of atypical femoral fracture. Teriparatide, it is an anabolic agent. It could be considered in selected cases. The evidence is limited. It may improve fracture healing and bone turnover. Romosozumab, again, anabolic agent. It has limited evidence only in small studies and case reports that suggest possible benefit. However, it's not standard treatment. And this preferred treatment is enzyme replacement therapy, which is asfotase alpha, because it is targeted therapy, which will treat the underlying deficiency, result in improvement of mineralization and healing of fracture. So asfotase alpha is soluble glycoprotein that is composed of two identical polypeptide chain. It is a tissue non-specific ALB produced by recombinant DNA technology. And it serves as enzyme replacement therapy for patients with hypophosphatasia to compensate for the deficiency of naturally occurring tissue non-specific alkaline phosphatase. What is the approval for the medication? It is already approved in many countries to be used for treatment of pediatric, perinatal, and infantile, in addition to juvenile onset hypophosphatasia. The recommended doses is 6 mg per kg per week, administered subcutaneously, either as 2 mg per kg 3 times per week, or 1 mg per kg 6 times per week. The clinical efficacy was demonstrated in multiple parameters, including improvement of skeletal parameter, overall survival, improvement of ventilator-free survival and respiratory status, biochemical parameters indicated by like plasma, vitamin B6, and inorganic pyrophosphate, physical functioning, mobility, and also growth in pediatric age group. Now, the improvement after starting asfotase alpha was demonstrated in multiple studies where they looked at the substrates of alkaline phosphatase, and they found that in comparison to the control patients who use asfotase alpha, they had significant reduction in the substrates of alkaline phosphatase, including vitamin B6 and inorganic pyrophosphate. In addition to that, initially during the use of asfotase alpha in the initial 6 months, there was no statistically difference in terms of Z-score. However, after the 6 months, there was improvement in the Z-score in multiple sites, including lumbar spine, total hip, and whole body BMD, and that was consistent over 5 years of treatment in this study, and it remained in normal range and it did not change over time. In addition to that, there was improvement in the walking ability after the use of asfotase alpha over 5 years of treatment in the group who used the asfotase alpha in comparison with baseline. And this is one of the parameters that it is usually followed during the treatment of hypophosphatasia. They usually assess improvement in the walk by doing 6-minute walk test. In addition to that, overall quality of life, it was demonstrated in the study that it improved after the use of asfotase alpha and different parameters in terms of less pain, better working capacity, better sleep, and better physical functioning. So to conclude, hypophosphatasia is frequently underdiagnosed and misdiagnosed. Persistently low alkaline phosphatase should always prompt evaluation for hypophosphatasia. Always maintain a high index of suspicion in patients with recurrent fractures, especially if it's metatarsal fractures or chronic bony pain. ALBL genetic testing confirm the diagnosis and enable family screening. Early diagnosis guides appropriate therapy and prevents harmful treatment and complications. Hypophosphatasia exemplifies precision medicine. Genetic diagnosis of ALBL variants enable accurate disease classification, guides targeted therapy, avoids harmful treatments, and facilitates personalized patient and family management. Thank you.
Thank you, Dr. Reem, for the interesting case. Actually, this is, if tell us anything, it tell us how is the proper approach to such cases can lead to a proper diagnosis and management. So just a quick reminder to all our audience, for the questions, please post it in the Q&A box, and it will be started after the next talk. So our next or third talk, it will shift the focus actually from the science to the responsibility. A genetic test now becomes more and more integrated in the endocrine practice, and this leads to more of ethical challenges. It is my pleasure to invite Dr. Ali Al-Bashri. He's a consultant physician in the Division of Genetics at Tawam Hospital. He has a triple US board certification in internal medicine, medical genetics and genomics, and medical biochemical genetics to discuss the ethical considerations in the genetic testing. Dr. Ali, please go ahead.
Thank you, Dr. Nora, for the kind of introduction, and I'm honored to be with you guys. I'm here as an embedded geneticist in the talk. Let me just share my slides. So my talk today is less technical compared to the previous two, and hopefully it will not be boring because a lot of the ethics is usually in talking about principles, but today I will talk about ethical consideration of genetic testing. I have nothing to disclose, but aside from the point that I'm gonna mention here, is not to discourage you. So my talk is not to discourage you about testing. I'm just trying to ground what it really means to do genetic testing in general. So my talk is not specifically for genetic testing in pediatric endocrinology or ALP or hypophosphatasia or MODY, but it's just in general to understand the scenarios and the perspective of genetic testing. So I have only a sole objective today, is to gain a little bit more objective about what does it mean to do genetic testing. When we talk about ethics, most, or at least I hope, all physicians don't have an ethics deficiency, right? So nobody needs an extra dose of ethics when we give a talk about ethics. But so what is it about? It's about the situational awareness, understanding the perspective surrounding a medical field or a medical topic, and the medical legal framework that arise from it. Genetics, just like Dr. Noura said, it's a very powerful tool, but just like what they say, great power comes with great responsibility. I may be quoting Spider-Man here, but the idea is, for me today, is give you a little bit more perspective. So why genetic testing is special? Why am I here today? Why are we having this ethics discussion about genetic testing and not, for example, hemoglobin A1C? Is there a, we don't have a lot of ethics discussions about other tests. Well, first of all, genetic testing leads to a forever result. A genetic diagnosis today in a 2-year-old will remain true when she's 80. It's not going to change. It's a forever result. But a potassium level, for example, a month ago becomes irrelevant to you after a year. It doesn't mean anything for you. And that's something that carries a lot of weight with medical legal purposes and a lot of other aspects in ethics in genetics. For example, nobody's going to be liable for a tiny bit of hypoglycemia that happened a while back, but the patient is fine now. But when you do a genetic test, you are creating a lifelong finding on somebody's record. So this carries a huge implication. Second of all, it's an identity test. You are not your potassium level. You are not your hemoglobin A1C. You're not your blood pressure. But your genes do make who you are, at least in part. So these tests are personal. There are a lot of heated arguments in the genetics clinic. Things get, heated. There can be a lot of guilt. There's going to be a lot of blame going around, possibly even between parents. Family dynamic can get affected. So all of these need to be taken into account when you do testing, when you do counseling. Third of all, it's a family record. It's probably one of the only tests when you do, you understand more about the family than not just the individual. So it's not an individual result. It's a pedigree of kind. So when you do a genetic test, you're creating information or liability about other family members. And lastly, genetic testing is very complicated. There's a lot of misunderstanding that happens, not just patients, even physicians, and how these test reports are generated. What I mentioned here, genome is not equal to a test report. It's important to understand. Genetic reports are unlike any other test. For example, if you order a electrolytes or basic metabolic panel, no lab will tell you, hey, potassium is a little bit low, but sodium is fine. I'm not going to tell you what the sodium is. You don't need it because I'm just going to tell you what's important for you. And that doesn't happen in any other test. But in genetic test reports, that's what happens. When you have a report, and this is by design, it's just you cannot have it any other way. You cannot have thousands of pages about all the genetic variations when you do genetic testing. So, and we used to get actually more pages before, like I remember in in the 2015, 2000, in the late 2010s, whole exome, whole genome tended to have a lot of pages, but more and more recently, labs just unify their reports. So it's important to understand when you do genetic testing, what's under the hood. Labs go under reach into the Pandora box and just pull something for you. But that something is 100% objective. That mutation is real. The validity of the mutation is not in question. It's very rare unless there's a sample mix-up or something. The real objectivity of the mutation is there. But the interpretation does add a lot of variability and subjectivity, because the subjectivity of the lab, they decide what to show you, and the physician has some subjectivity in telling you what is important, if this mutation is important or not. All right, so the core principles of medical ethics, these are not changeable. These are not different between specialties. They are the same. But the questions that revolve around genetics actually span all of them, really. A lot of them revolve around autonomy, There's autonomy is respecting a patient's right for self-determination and decision-making regarding their own healthcare. In terms of genetics, there is a specific caveat, which is you are, in essence, in pediatric at least, you are offering a forever test for a child. And what does that mean for their autonomy, for their right to have an open future? And number two is beneficence, which my colleagues covered greatly. There's a lot of benefit of doing the genetic test, and there is a professional obligation to act in the best interest of the patient to provide therapeutic benefit. In terms of genetic testing, again, there is extra special stuff because when we do testing, again, there's a competing principle here, which is the duty to warn family. And this can compete sometimes with confidentiality, depending on the scenario. Believe it or not, some cases, even in the US, there have been cases that actually the physician lost because they did not warn, because sometimes it can break you can break confidentiality in certain circumstances. This obviously depends on where you are, where you practice, but it's something that to keep in mind. Non-maleficence, again, this is very well known. First, do no harm and avoid unnecessary suffering, risk, or injury. And unfortunately, with genetics, there can be a lot of problems when you do genetic testing. Again, dealing with guilt. There's a lot of guilt sometimes because you feel you gave your child this mutation. The diagnosis comes a lot of times if it's inherited from the mom or the dad. And it can affect engagements and can affect marriage and family. The other thing is a child knowing about their adult onset diagnosis. For example, I'm giving you an extreme example of Huntington, which we don't do at all now because this is a big no-no in genetics. We don't do pediatric testing for adult onset and treatable conditions. Or this is much more common, misinterpreting a genetic diagnosis or genetic result, causing unnecessary surgeries or treatments. It happens everywhere. It happens to the best of us. And it is challenging sometimes, but always understand that when you have a variant that is not clear, refer to your geneticist. Lastly, justice. This is a system issue, ensuring fairness, equity, and appropriate distribution of medical resources and treatments. It is actually a very challenging topic with genetics because these are usually very expensive. The genetic results can cause discrimination at work or getting insurance. For example, we do have the GINA law in the US, which is in 2008, where it prohibits discrimination in certain insurances. But for example, in life insurance, you don't get protections. In long-term disability insurance, you don't get protection, which actually matters a lot in a lot of the genetic dementias, for example, or neurodegenerative diseases. So with genetic side of ethics, there are competing principles. I mean, they're all correct. It's just different sides to it. And they can collide. And they're both good. They just don't always run in parallel. So for example, what is good for the family, what is good for the siblings, and when you test a child, sometimes you test a child for the sake of siblings. And in genetics, a lot of times, actually, we do have the unit of care is the family. Even if we don't have a direct physician to patient relationship with the rest of the family, it is our unit of attention. So this is a unique side of genetics. And just to go back to the whole course of medical ethics, with autonomy, it's important to understand the part of informed consent. And this is why a lot of times we get referrals to have this consent. It's not a simple thing. It's like a procedure, right? Because we actually have to sign every single time when you do genetic testing. It's not a click of a button. And for children, there is another part of it because the dad or mom is signing. There is the concept of paternalism. They are deciding for the child. And you have to, counsel about the things that could happen. For example, the right not to know. Because when we do large genomic sequencing, for example, whole genome sequencing or whole exome sequencing, we can have an opportunistic chance to find secondary findings. And these are, specific list is 84 genes now, and it's growing. It used to be 53. and they need to understand what are they signing up for. What is the scope of the genetic test? How many genes are you testing? What is the possibility of false positive, for example, variant of uncertain significance, or false negative? We always mention the false negative because that sometimes does not reduce the risk, even if the patient is negative genetically. So pre-test is very important. We do that even pre-test before post-test, and obviously when they come back, we counsel them again, and we've highlight the points. Even if the test is negative, what does it really mean? And moving on to confidentiality, this is the burden to protect the genetic information when you counsel, and it's very tricky because you are sometimes seeing a lot of the family members at the same time. I mean, you may see the brother or the sister, how much you protect, how much they actually know, and it's a very delicate balance of how how you interview, how you ask questions. Liability, this is a big one because what happens when you have a variant of uncertain significance? Somebody has to follow it up, right? And we used to have a lot of these. Thankfully, now it's getting less and less with more genetic knowledge, but we still have them on routine basis, a lot of genetic variants of uncertain significance. So these variants that are not determined to be pathogenic or benign, somebody got to follow this up. Because again, these are lifelong. What happens if this gets reclassified and the patient is lost to follow-up? They come back after 10 years with a very bad complication. Who is liable, right? Lastly, equity. This is protection against genetic discrimination, social stigma, and it's more of a systemic issue here. So going back to the parental paternalism, there's a core concept, which is the right to an open future. So this is not like how a mother agrees to give a child antibiotics when they are in the emergency room, for example. These are decisions that will have big implications on the child's future. And the principle of autonomy here is we are trying to test and report, even the lab has to report what can actually be actionable. So what affects the management, how does it help with screening, for example, in cancer predisposition, or for example, some circumstances we do genetic testing for also pre-symptomatic and treatable conditions to get them to a research trial. For example, when somebody comes in with pre-symptomatic ALS, there's a family history of ALS, and you do genetic testing because there are gene therapy trials, for example. In these circumstances, it is reasonable to do testing. Also, which is also equally important, even if it's untreatable condition, ending a diagnostic odyssey is a goal of itself, even if it's untreatable. And to have an answer, just to have an answer, or at least in terms of medical investigations, you just stop doing more investigations because you reach the diagnosis. There's an exception of the right to open up future, how we counsel children, the parents of children, which is the American College of Medical Genetics. They do recommend certain list of 84 genes now, and a lot of them do have adult onset certain disorders, which is okay. In this scenario, they sat together for many, many times, and these are vetted group of conditions. And this is an opportunistic scenario that also helps the parent. And this is one of the sides that actually vindicates or approves why we would do genetic testing for a child, because it is in the best interest of the child to have an alive parent, right? So it is important to also take care of the parents too, even for the child. So these also matter for the parents, right? Non-actionable results. A lot of times when patients come in or parents come in and want to ask for a test for the child for a non-treatable adult onset condition, our answer is no, we don't do that. Or a lot of times we actually get this too, intentionally testing for carrier status for a child, which is not ethical. They get to decide this when they are adults. So the limits of genetic testing. It's important to understand pre-test counseling is important, and it's important to tell what a positive is. Does that mean what a positive means, what a negative means, and oftentimes negative does not exclude a genetic diagnosis, or at least let's say familial kind of inheritance, because there are a lot of even endocrine kind of conditions, for example, diabetes, is actually a familial, right? So it's the monogenic MODY is the rare subset, but even the type 2 diabetes is genetic. It is not monogenic, but it's genetic, so it is familial, and it's important to explain that to the patient who gets tested. Even type 1 diabetes has genetic elements, so all of these, even if it's a negative genetic test, it's important to explain what that means to the patient. Variant of uncertain significance, this does have very important ethical consideration. And the potential for reanalysis. It's important not to close the door. And that happens sometimes when, even for the physicians, when they hear, oh, they did a genetic test and it's negative, it's over. No, it's not really over because genomics improve. Genes don't change, but our understanding to these genes change over time. So we can do reanalysis or retesting in the future, or even genetic technology improves. So we do have a variant classification. Any single variant or gene, we don't call them mutations anymore. We call them variants to help understand that variant mutation is not always harmful, because you can have a likely benign mutation. And a lot of people may, I think, and certain mutations lie right in the middle, which is 50-50, which is not true. And certain variants can be 30% likelihood of being pathogenic, can be 80% likely pathogenic. Likely pathogenic is around 80 and 95 or 90 to 95% likelihood of variants being harmful is classified as pathogenic, and likely pathogenic, sorry. Pathogenic and benign are 99% sure they are benign or pathogenic. This is not just to show you how complex it is to classify variants, and this is not the only list, trust me. Even labs have every lab has its own version as well of how they classify variants, and it changes over time. So just understand it's a very complicated matter. So I like to give, this is especially important to understand the dangers of the VUS. And I give this example in situations where patients come in for family history of cancer. Because what if I tell you, let me give you this scenario. Imagine you go to the doctor and they tell you, well, let me put you inside this powerful whole body imaging machine, like it's powerful than a PET, for example. And let me tell you, I may find something there, but I may never, or may or may not, it may not be cancer. We don't know if I find something, but I can never figure it out after. How are you going to feel about finding a lump that you cannot biopsy? And this is how I sometimes give an example to this. If somebody has a variant in MEN1, for example, it's a VUS, and you cannot figure out, only time sometimes give you, when other people find it in other patients, you can reclassify it. It is a very distressing thing. And this is, I give this example a lot for these patients to understand what are they signing up for when they do genetic testing. Another danger of VUSs is what is coined as a Ulysses syndrome or Odysseus. For those who may know Greek mythology, Odysseus is the king of who left Trojan War and had a 20-year journey. And this is why they call diagnostic odyssey as an odyssey, because it comes from Odysseus. So Odysseus syndrome is where somebody goes through the healthcare system and they go often into many dangerous or pointless adventures. And I mean, as just like the King Odysseus for 20 years. And at the very end, they just go back where they started. And this can happen with the VUSs. They may lead you to MRIs. They may lead you to biopsies, other investigations. And you, in the end, may go back where you started. There's another definition for Ulysses syndrome, but that's the older one, where that's what happens sometimes with stress from accessing healthcare system for patients. And there is also the patient or even provider misunderstanding. There was a study in 2019, 75% of doctors recommended unwanted interventions because of VUSs. So these variants of uncertain significance are not harmless. So the standard practice, when you have a VUS, treat the phenotype, not the genotype. And these VUSs are typically innocent unless proven guilty. Refer to your geneticist. We will try to figure it out. Sometimes there are other ways, for example, de novo mutations versus inherited, or some other analyses we can do. All right. This is an extreme example, and it was part of how the medical genetics ethics came to be in the 90s and 80s, because testing for Huntington, which is a very horrific adult onset progressive intratuberable condition, caused so much harm for those who tested for it. And that can, and we don't test children. This is not recommended, unless in the very rare circumstances when there is a pediatric onset anticipation. But this is a double-edged sword, because negative results may provide relief, but positive results, oh boy, that's going to be very profound stress. And even for children, for example, if the child was tested, like in some cases in the past, the parents may look at them in a different way. For example, they may not pay them for college. They may not give them enough attention, or these things can happen. Testing positive can lead to depression, anxiety, or even suicide, or problems with family. Because when you test, for example, it may inform for example, if the parent or the dad or mom has not been diagnosed or not being tested, but in the family there is a case. So if you test, you in a way can tell if your dad is affected if you are positive. So this is something can affect the diagnosability of the dad or mom. And there's actually a way when we do PGTM or IVF, when the son and the son is the one who is going to have a child, for example. They would submit their samples and they do a de-identified marker to test the embryos without the dad knowing if he's carrier or not, for example. All right, this is another situation which is relevant to endocrinology, which are what we call the social emergency, because it's really an emergency, which is the crisis of undetermined sex at birth, or the need to change sex when there is a genetic diagnosis revealing that the biologic sex is different than the announced sex. So this is a very, very, very stressful. I don't envy the parents who are in this situation, because especially how can you congratulate? How can you announce a child when you don't know if they are male or female, for example? There's a lot of stress. There's culture pressure, requirement for also from regulatory element of birth certificates, civil registration. It is important to understand that genetic testing takes time, right? So the resolution for this, a lot of times, can outpace the turnaround time for genetic testing. So there's a high stakes decision. It's hard to reverse, hard to, or socially. There's also the risk on the child's gender dysphoria or loss of reproductive potential or psychological trauma. And it does need a multidisciplinary approach, multi-specialty, rapid response, and careful counseling. And when you diagnose somebody, it's really important to understand also the stressful situation of what about the siblings now? Are they also males, but they are females, or females that are males? So this is also, a problem. And this leads us to cascade testing. This is the concept of doing testing for family members at risk. And this is better handled in genetics clinic because we do pedigrees and we, try to catch up and try to find who can get tested. All right. So last thing here with the genetic testing is sometimes, and this is a very horrible, unfortunate scenario, sometimes when you do a trio means child, dad, and mom, sometimes you can find misattributed paternity. It can happen. Or what's worse, cases of criminal cases, for example, incest or sexual abuse, when you find very high homozygosity between, in the genome. Finally, but it's also important, is understanding the backdrop of culture, right? In genetic testing, it's part of the culture, how it affects the people in this culture. There's a stigma, and there are issues with, for example, khutbah or marriageability. If there's somebody who's positive, and then what about their siblings? And what about the other people who could hear about this? Or when you try to counsel about risk reduction, don't marry your cousin, for example. And we live in a culture of consanguinity. There's a lot of careful counseling here. And lastly is the prenatal genetic testing, and there are legal and Islamic consideration for abortion. So in summary, genetic testing is not a click of a button. think of the family as you request or order genetic testing. Be aware of pre-test, post-test genetic counseling, and consider the downsides of genetic testing. I will say, in genetics, my mentor used to say, you gotta be used to say, I don't know, if you are gonna be in the job of being a geneticist, because it's one of the hardest things in medicine to say nothing or do nothing or say, I don't know. And there's a saying in surgical fields, it takes months to learn how to operate. It takes years to learn when to operate, but it may take a lifetime to learn when not to operate. Thank you for listening.
Thank you, Dr. Ali, for this interesting talk. And actually, it is more of a thought-provoking talk. I'm going to invite all the speakers, please, now to attend our Q&A session. We had already three excellent presentations so far covering the spectrum of the precision endocrinology. So let's open the floor for the questions and discussion. And let me start. We'll try to cover as much we can in the next 10 minutes. So let me start with Dr. Hissa. I'm not sure if she's around.
Yes, I'm here, Dr. Nora.
Thank you. So Dr. Hissa, the question this is regarding the monogenic, actually Moody, regarding more of the Moody. What is the prevalence and incidence of Moody in our region? Do you think it is different from other parts of the world or globally?
Actually, for Moody, if we take it in general for monogenic diabetes, it's count for 1 to 2% of all over types of diabetes, which is rare. For Moody, it's more rare, but for our country here in the region, unfortunately, I think we still have underdiagnosed cases. So the prevalence is very, very low. I don't have exact number, but it's very rare and it's still underdiagnosed.
Thank you. I do agree with you. It is underestimated, probably because of this issue of the genetic test, which is not available everywhere, right?
Yeah.
Thank you. Okay, moving to Dr. Reem. Dr. Reem, how frequent do you think we are missing the low ALB level in our clinics?
Well, as I mentioned in my presentation, most of these cases, unfortunately, they are lost between different clinics like rheumatology and orthopedic clinics, and they are misdiagnosed with different diagnoses like fibromyalgias and other diagnoses, as we saw in our case. So just keep in our mind that this cause could be an etiology that needs to be looked at. So once we think about the diagnosis, we will look for it, right? If we don't keep it in our mind, then we will keep missing it. That's why we have to keep it in our mind as one of important differential to be ruled out. And a simple test like alkaline phosphatase could give us a hint that this could be the etiology of this patient presentation. So yeah, it is commonly missed. And we found like in this patient, she already had a test years before she presented to our clinic, and nobody looked at that level. So we just need to keep it in our mind as one possible etiology, and then we have to go from there.
Actually, it is unfortunate because, as you said, it is an uncommon disorder, but to start with, it is a very common lab test available everywhere. So missing this lab, I think it is a crucial point where we probably need to consider more of awareness, right, among our healthcare providers to not miss this.
Sure.
Yeah, thank you. So the third question here is regarding the counseling, which I believe for Dr. Ali. So how do you think, Dr. Ali, the clinician should handle the incidental findings in children when these findings may affect the parents or the siblings?
So it depends on where the test was done. So if it was done in the genetics clinic, obviously the geneticist will handle that. But if it's important to when you do when you do the test, and you might, I mean, these tests are, proliferating now, so you can, order them in a lot of places. And please tell them what the results are, because it's, again, it's the family or the patient will feel kind of betrayed if they were referred and not told what was the results first. I think the secondary findings, it is very important to highlight these are likely to be inherited, but not necessarily. Could be de novo. Because this list of secondary findings, the 84 genes, most of them are inherited. I mean, there are genes that are frequently de novo. There are genes that are inherited. Cardiomyopathies frequently inherited and not de novo, for example. And half of the genes there are cardiomyopathy and cancer, or more, actually the other half is cancer. And most of the cancer are also, cancer predisposition are all mostly inherited. So it does matter to tell the parents, because when you refer, you don't know if they're going to show up. You don't know if they will follow in the clinic. So you let them know first and tell them, I'm sure you're going to have a lot of questions.
Yes.
And promise that, with the genetics counselor or the genetic doctor will help you with navigating this.
Okay, thank you, Doctor. Another question actually for you as well. When do you think, or you can see the genetic test in front of you is considered to be more on offer testing?
Oh, that's a tricky one. Well, unfortunately, it is a common theme everywhere, really, but it's something that the over-testing, well, let's say, if somebody comes to genetics clinic with an expectation, a lot of the physicians will have either to fight or the resistance, because the patient wants something to be done. It's hard sometimes to talk them down of maybe not. And it's something that happens. Sometimes we just tell them not to do. Eventually they decide not to do testing. But we do see that. We do see a lot of over testing. And in situations when there's over testing plus a variant of uncertain significance, or honestly, even pathogenic and likely pathogenic, I am questioning if that's somebody who's pre-symptomatic. Could be even the pathogenic and likely pathogenic. It's a very different story when you do testing or over testing, which means somebody's not even symptomatic or doesn't fit the criteria at all, and they have a result that's discrepant between the phenotype and the genotype. The mutation is there for sure, but what does it really mean is a result of an over testing that happens.
Thank you so much, Doctor. So going back to Dr. Reem, at what point in the diagnostic pathway should clinicians strongly consider genetic tests and suspected hypophosphatasia?
So,
when you do the genetic test, yeah.
So we have to start first by the simple test, as we said, which is the alkaline phosphatase. That will give you the hint to proceed further, keeping in our mind, of course, the history of the patient. So if the patient already presented with the typical features like recurrent fractures, especially if it's metatarsal fractures, and already had the other features like the dental problems, the other musculoskeletal manifestations. So the first step I will do is the alkaline phosphatase level. If I find alkaline phosphatase less than 40, that will drive me to do further testing. If vitamin B6, for example, is available in the lab, it could also support the diagnosis. And then to confirm the diagnosis, we have to do the genetic testing, because the treatment and the enzymatic replacement is not available everywhere, and it's expensive medication. So nobody will treat such case unless you definitely confirm the diagnosis. So to confirm the diagnosis, after establishing the other supporting evidence, we have to do the genetic testing.
Thank you, Dr. Reem. Because of the time, we'll take the last question, which is for Dr. Hissa. I believe, Dr. Hissa, already you did mention this in your presentation, but I will ask you just to, if you can summarize when you need to suspect monogenic diabetes. Or sorry, yeah, monogenic diabetes. Yes.
Yeah, okay. So when we have
I will just summarize it in this sentence. If we have any classical presentation of either type 1 or type 2, we need to suspect something else like monogenic diabetes. As we said, if type 1 patient, the patient is BMI is normal and the antibody is absent, family history, we need to suspect monogenic. In case of type 2, if the patient is actually a young patient, non-obese, no family, there is family history, we need also to suspect type monogenic diabetes. The problem is that sometimes we get mixed cases, which is not very clear. But if you suspect, you feel that something wrong, and the management or the patient is not responding well, you need to think of something else other than the classic diagnosis like type 1 or type 2. Then we suspect, then we need to do we can use the calculator, the risk calculator, and this can guide us actually to do the genetic test if needed.
Okay, thank you. Thank you, Dr. Hissa. Thank you, Dr. Reem and Dr. Ali, for your excellent contributions. And by this, we end the Q&A session and we'll move directly to our sponsor symposium by Surveyor. And this will be the dyslipidemia, streak early, streak strong. It will be presented by Dr. Nisreen Al-Ghazal. She is head of endocrinology department and endocrinology consultant at the MedClinic Middle East, Dubai Mall. Dr. Nisreen, the floor is yours.
Yes, thank you so much. Excuse me. Okay, let me just share my screen. Okay, here we go. So good evening, everyone, and thank you for staying with us till this time. So my name is Nisreen Ghazal, and I've been in the UAE for almost 10 years, and I'm currently in MediClinic. I'm an endocrinologist. So we're going to talk about dyslipidemia, strike early, strike strong. I'm going to try to be brief and clear. So I'm engaged by Servier to give this presentation. I have no disclosures or conflict of interest. So we cannot start any presentation without talking about prevalence. And dyslipidemia is a very high prevalent disease, as we can see. You can see here the Middle East map, and these are really significant numbers. So we're talking 80% Jordan, 85% Kuwait, UAE 44 to 75% according to the studies we're looking at. Qatar high, also 40%, Lebanon 80%. Now, it is a highly prevalent disease, one cannot argue, but with this high prevalence, we have three major challenges. The first thing is that we're going to see it in future slides. There's a very low control rate according to the latest LDL guidelines. And we know that the latest LDL guidelines are quite tough and quite strict. And sometimes we struggle in the clinic to convince the patient to intensify the treatment to reach this. The second thing is the low adherence to therapy. We see it every day. The patient is on statin, the lipid profile is quite uncontrolled. When we call the patient, he or she will say, yes, I do take it on and off. The third thing which we struggle with diabetes, with blood pressure, with lipidemia is clinical inertia. Wait on the LDL, advise more lifestyle changes, let's retest in 3 months. And then this will give us more and more time of exposing our vessels to plaques and inflammation. So we talked about prevalence, and then we talked about the challenge, and here is an illustration. Let us look at the achievement, like how much of our patients are achieving the LDL targets according to the new guidelines. Now I'm going to talk later about who's low risk, who is moderate risk, who is high risk, who is very high risk. But let's look at this just quickly in a glimpse. You see that the green parts are those with an LDL of less than 70. And you see that as you go with the risks, most of our patients, unfortunately, are not on target. Therefore, most of them are not protected optimally. So we talked about lipidemia, how prevalent it is. But it's not more important that it's prevalent. What's more important is that this is not a benign pathology. Because a high LDL, typically in all the studies, and this is one illustration, does increase the prevalence of atherosclerosis, and this is why it's a harmful condition. So let's look at this graph. You can see that the red ones down, the red boxes or the red bars, mean no atherosclerosis. And everything that's up from gray to orange to blue means atherosclerosis involving one vascular site or more. And then the horizontal line is the LDL. And as you see, as we go up in the LDL, starting from 50 to 60, reaching to more than 70, up to 160, our risk of involving more vascular sites with atherosclerosis is increasing significantly. Now, next step. So lipidemia is prevalent, it is not benign. So if we reverse it, do we reverse the deleterious consequences? And the answer is yes. And this is a very big trial. This is a landmark meta-analysis, actually, of more than 300,000 patients. And this is in 2016. And it has many trials, but the most of them were on statins. So 25 trials on statins and the rest between niacin, fibrates, ezetimibe, PCSK9, etc. And we do confirm that each 1 millimole reduction in LDL is associated with about 23% reduction in major vascular events. So the reversal of this pathology confers with it positive cardiovascular benefits. And this is why, in the end, we treat the LDL, not for the number per se, but for the deleterious consequence and for the cardiovascular benefit. So yes, lowering the LDL gives the patient cardiovascular benefits. I want to introduce this concept that really there's a change in paradigm. So when I started practicing, we used to treat low-risk patients with an LDL of more than 190. We were more lax, more reluctant. Okay, let's reach an LDL of less than 130 in most patients if they're high risk, less than 100. Now the cutoffs are much more tight. And now the lower the better up to a certain extent, and a larger percent reduction is better. So if we look at this registry, this is a registry from Sweden that takes all the patients that are post-myocardial infarction. So these are definitely high-risk patients. And we can see that, let's take the graphs, whenever we reduce the LDL more, so the patients that have further LDL reduction, they had better cardiovascular advantages and less hazard ratio, lower hazard ratio of all outcomes, including all-cause mortality and cardiovascular mortality. So if we look at the second graph, this LDL reduction, the minimum is the orange and the maximum is the purple. So you can see that as we control more and we reduce more our LDL in patients post-MI here, we gain more in terms of we decrease the risk of deleterious cardiac event. So yes, here at this point in patients post-MI, the lower the better. And now these are the guidelines we are following. These are the European Society of Cardiology and European Atherosclerosis Society guidelines that really shifted the management of lipidemia. And here, this is the 2025 update talking about when can we use an early combination therapy. So these guidelines, they do reinforce early diagnosis. And they do talk about upfront statin plus ezetimibe in patients who are initiation, in patients who are ACS naive patients. And we will talk about this alongside with an updated score 2 risk. So there's a new cardiovascular risk assessment in those guidelines. It's called the score 2. And there's another one for older people. It's called score 2 OP. So this actually is an important score that can stratify the patients, but this will be mainly used for patients without risk factors and those who we do not know where to put them. Are they low risk? Are they moderate risk? Are they high risk? The second concept in this update is strike early and strong. So diagnose early, treat early, intensify the LDL goal achievement, and from the beginning, if you see a patient with acute coronary syndrome, and if you see that the target LDL cannot be achieved by statin only, depending on the percent reduction you need, then this is an indication to start the combination from the beginning. So stepwise approach is definitely still recommended. So statin and then increase. And we have new agents like bempedoic acid, etc. But also there's a big place here to think about the combination from the beginning according to the target, and I will explain this further in the next slides. So I said, I'm going to tell you who are low risk, moderate risk, high risk, and I'm going to do this briefly. So basically, low risk patients are patients without any risk factors. And when we calculate their score, it will be less than 2%. And for those patients, we are aiming for an LDL of less than 116 milligram per deciliter. Then we go to moderate risk patient, and those have a score of more between 2 and 10%, but those are also the young diabetic patients. So the type 1 that are less than 35, the type 2 less than 50, or those who have diabetes for less than 10 years. And for those, we target an LDL of less than 100. Then you go to high-risk patients, and those have a score between 10 and 20%. But those are patients who, for example, have an LDL of more than 190. So this alone puts them at high risk. A blood pressure, second degree blood pressure, more than 180 over 110. The familial atherosclerosis, the moderate CKD, and the long diabetes, so more than 10 years, or with an additional risk factor. Okay? Now, the very high-risk patients, and the high risk, we target an LDL of less than 70. Now we have those very high risk, and those they have ASCVD. So this is either clinical or through imaging by calcium score, etc. And they have a score to more than 20%. They do have a family history with ASCVD and other risk factor, severe CKD, or the patients with diabetes with and organ damage, more than 3 major risk factor, or very long for diabetes, for example, more than 20 years. And for those patients, we are even more aggressive, and we target an LDL of less than 55. And there's a subgroup we call extreme risk. These are patients who have an event despite being on statin, or patients who are polyvascular, they have polyvascular involvement. And those patients, for example, let's say he has an MI and he's already on statin, and we recommend an LDL of less than 40. So the novel thing here in patients in this updated guidelines is in patients with acute coronary syndrome. So they do say that intensification of lipid-lowering therapy during the ACS hospitalization is recommended for patients who are already on lipid-lowering therapy before admission, because it means their LDL reduction is not enough, or is not enough to confer heart protection at least. So it is recommended to intensify, and initiating combination therapy with high-intensity statin plus ezetimibe should also be considered even if the patient is not already on statin, because once he is admitted with ACS, as we know, he is already a very high-risk patient. And then we will calculate what is his LDL, what is the target LDL? Can we reach it with statin only? If this is reasonable, then it's statin. If it's not reasonable, then the combination can be started from the beginning. And this is the update here in those ESC-EAS guidelines. So I was saying, can he reach his target with statin? So what target can we reach with statin? So let's look at the statins here. And let's look at the high potency statins, because this is the maximum we can reach. And here we're talking about atorvastatin and rosuvastatin. And according to the doses, definitely, but they can give us up to 50% reduction. So here they're advocating this test, treat to target. So let's say a patient here is coming, and we're targeting, according to the stratification, an LDL of less than 55. And he's coming with an LDL of 110. Then this patient needs more than 50% reduction, and it might be reasonable to start the combination from the beginning. So this is a summary of the different modalities to treat the cholesterol and how potent they are in terms of percent LDL reduction. So we're talking about moderate intensity statin, which are honestly the bulk of the prescriptions, and this is 30% reduction. And then we have high intensity statin, they can give us up to 50%. So just for simplicity purposes, in our mind, if anyone needs more than 50% reduction, then we must think about the combination, because this is where we can reach up to 60%. Then anything more than 70 or 80% will require us to add PCSK9 inhibitor. Now, let's also compare if we give the statin alone to versus giving statin plus ezetimibe. And here we're talking about rosuvastatin and rosuvastatin versus ezetimibe. Comparing dose to dose, so 5, 5, 10, 10, 10, 10, 20, 20, 10. So the combination obviously gives better reduction in LDL cholesterol, and we can reach up to 63% with the 20-10 combination, which we cannot reach using the statin high dose alone. And let's talk also about something that we face in the clinic, because so many times the patient comes to clinic and then let's say he is on atorvastatin and he is not controlled. So I would think in my mind, so why don't I increase it from 10 to 20? And here the study is showing that doubling the statin dose is inferior in terms of LDL reduction compared to adding ezetimibe. And this applies to simvastatin, atorvastatin, and rosuvastatin, and the difference is clinically significant in all three statins. So adding ezetimibe to statin is more effective than doubling the statin dose. And I actually like this slide as well, because it shows us the end result of lowering our cholesterol. So just to explain to you, if you look at the orange ones, these are the patients on rosuvastatin, and they did achieve 36% LDL reduction. But in this trial, the patients who were on the combination, and I want you to look at the blue ones, they did achieve a 55.8% decrease in the LDL, percentage lowering. But that's not the most important part here. If we look at the right part of the slide, we see the vascular ultrasound. So they did vascular ultrasounds, looked at the vessels, and saw the patients on combination and the patients on the high-intensity statin alone. And they compared the coronary plaque volume. And because this is what's important, this is what will cause deleterious consequences. And there's a greater reduction in the coronary plaque volume that is statistically significant, with a significant p-value in patients with the combination. And another trial that I will go over quickly is the racing trial. And this is a non-inferiority trial. So this was the purpose. And it was conducted in South Korea. And we're comparing basically high intensity versus moderate intensity, so lower intensity statin plus ezetimibe. So here in the back of our mind, we're saying we want to check of course, the endpoint, the cardiovascular events, but also the tolerability and safety. And I'm going to show you the results. So when we're talking about primary outcomes, so cardiovascular death, major cardiovascular event, and non-fatal stroke, the combination versus the high-intensity statin, they were non-inferior. But this is more important, because more patients in the combination achieved LDL cholesterol less than 70. And this you can see at 1, 2, and 3 years. And the combination are the orange ones, and the blue one is the high intensity statin. But also, what we see clinically is that fewer patients in the combination with a moderate intensity statin discontinued or reduced the dose. I mean, myalgia in the books is not common, right? Statin-induced myalgia in the books is not common. In clinic, it's quite common. I mean, patients do complain about it and do stop the statin and do try without it and feel better. And we see that when we lower the dose or we combine it, the myalgia consequences and complaints are less. And this is really here shown in this study as well, that the patients tend to stop less the combination because they were complaining of less myalgia. And finally, I want to show you also this slide, that when someone, or this applies not only to the combination of statin and ezetimibe, but to any combination, that adherence when you take a single pill combination is much better than you take a free two pills separately. And the adherence is definitely here in this study was much better on the patients who are on the fixed dose combination versus the free combination, so the FCG. And this adherence was better in patients who are very high risk, and moderate risk. And also, there's a higher proportion of patients reaching their target when they're taking the single pill combination. This is because basically they are more adherent, but also there's a synergistic effect taking two medications together. And this has also been replicated in other diseases, not only in lipidemia. So the patients were more adherent, and this is the first graph, and down they're showing that they are more likely to reach their target level. So in summary, LDL cholesterol is a cause of atherosclerotic cardiovascular disease. So causality is very well established, and reversing it, so LDL lowering reduces cholesterol and therefore cardiovascular events. The ESD guidelines, they propose more intensive and aggressive LDL cholesterol goal. Most high and very high risk individuals do not achieve the proposed LDL cholesterol goal. Therefore, to keep in the back of our mind, according to the final result, maybe to start upfront with a single pill combination, specifically in the subgroup of patients, the acute coronary syndrome, to get to target early and efficiently and to expose the plaques last to inflammation and atherosclerosis. With that, I want to thank you, and that's it for the presentation.
Thank you so much, Dr. Nasreen, for the excellent overview, as well as the updated guidelines in dyslipidemia.
Thank you.
Thank you, Doctora. So by this, I believe we reach the end of the webinar. But before we end, actually, I would like to invite you to two an interesting activities coming soon. The first one is the CREATE. It's a learning initiative by EDAS and Sharjah University regarding research ethics in DHA by Ms. Midha Al-Kalkarni. And this should be by tomorrow, actually, at 7:30 to 8:30. And here you can see in front of you the QR code for registration. The other activity is Dyslipidemia Masterclass Webinar Wave 2, the Guideline-Directed Therapy and Therapeutic Sequencing. This will be done on 30 June, Tuesday, 6:30 to 8:30. And the same, you can access the code for registration. A final thank to all our attendees today. Thanks to the Young Leaders Forum. The CME will be available in 4 weeks after the webinar. And what you need just to fill out the evaluation form, please, that will be sent to your email to obtain the CME points. Webinar will be available on demand as well on the EDES Institute website and the EDES YouTube channel. And you can visit the website to have a look to all our upcoming webinars as well. Thank you all, speakers, attendees, team. And it was my great pleasure to be here today. I hope you enjoyed it as I did. And see you, inshallah, soon. Good night, everybody.